So it is Elizabeth again. I am a labor and delivery nurse and certified childbirth educator, Nurse Zabe here on YouTube, and I am back with another video. I want to apologize that there was such a gap between my one video I did in October and then this video, which may be going up on Halloween, which is when I'm filming it, may be going up tomorrow. But I had some big changes at work. I was night shift for the first 4 years of my career. Then I switched to day shift for the last 2 years, and now I'm doing kind of split. So I'm doing every Tuesday day shift and every Friday night. I'm part-time, so I work 24 hours. And unfortunately, with me not working Friday night, I have less time to film because Friday was one of my big filming days because my daughter is in preschool on Friday. And then also last week we went to Disney World, which was super fun and magical and amazing, and I'd never been before, and basically now I'm a princess. So I apologize for the lag in videos, but I wanted to thank you guys so much for watching and subscribing and commenting and liking and all of those wonderful things that you did, because of you guys we are going to be able to donate $500 to Now I Lay Me Down to Sleep, which, trigger warning, I'm going to discuss infant loss for about 2 seconds, is a non-for-profit that takes pictures of babies who are born sleeping. I also want to apologize for not putting a trigger warning at the beginning of my last video. I didn't because I don't think that we should be afraid to talk about infant loss in a way that would be alienating to those who have experienced it. But at the same time, I should have realized that my audience is made up of a lot of pregnant women, and I also don't want to bring you guys undue anxiety. So I apologize for I don't want to even call it a trigger warning. I want to apologize for just not kind of saying I'm going to discuss infant loss. If you would prefer to not watch this part, skip ahead to what time. So I apologize, but thank you guys so much for watching my videos and commenting and liking and subscribing, because we're going to donate $500. So I really appreciate that. Anyway, so this video is going to be 10 myths about pregnancy and labor that your nurse wants you to know the truth about. A lot of these are kind of like half-truths or things that are just flat out wrong. So we're going to go ahead and get started. Real quick, I just wanted to let you guys know I have like my next 10 or so videos planned out. Still doing research on some of them, but one that I really wanted to get out because I have a lot of frequently asked questions is frequently asked questions with a labor nurse. And if you guys have any questions that you want answered, definitely leave them down below. I know I had asked before for these, but I asked at the end of a video, so now I'm going to ask at the beginning. Also, one question that I get asked a lot is, do you have other social media or Instagram? So I have made a Nurse Zabe Instagram account. It's just Nurse Zabe. If you want to follow me on there, I'll be posting stuff about labor and breastfeeding and all that other fun stuff. Okay, back to the video. These are in no particular order either. So the first one I want to start with is colostrum versus no milk. So a lot of women, when they first have the baby, and a lot of times this is a cultural thing as well, don't think that they have any milk. And while you do not have mature milk, you have colostrum. And in my breastfeeding video, I talked all about colostrum. But basically, it is an amazing substance that is made to be your baby's very first meal. And you do not need to, unless through the guidance of your lactation consultant and your pediatrician, need to give formula because you have no milk, or until your milk comes in. Your baby's belly is very small, and the amount of colostrum that you produce is equivalent to how much the baby needs in most cases. So there is a big difference between having no milk, which only about 5% of women are unable to produce enough breast milk for their babies, given the right support and experience and guidance, than women who just have colostrum. And you don't have a lot of colostrum, and that's normal. You should only be really making milliliters of colostrum at a time. The pump's not going to get it out as well, which makes you feel like you have no milk, but an effective latch from a baby is going to be able to get out the colostrum that they need for their first few days of life until your milk comes in. So that is number one, that you don't have any milk when you first have your baby and you need to supplement with formula. Not true. In rare cases it is, again, discuss with your doctor, but in general, not true. These are generalized myths, okay? So, number 2, that you shouldn't get your epidural too early because it will run out. So, epidurals, maybe back in the day worked that way, but how we have them now is on a continuous infusion, and often with patient-controlled aspect to it as well. So you'll have a continuous infusion of medication and then a button you can hit to bolus yourself to give you an extra boost of medication while monitoring that you don't get too much. These machines are very, very smart. Now, there are reasons not to get an epidural too early. It's really important in the early stages of labor that we're up and moving around to get the very best positioning for baby. And the epidural doesn't lengthen labor per studies, but it can lengthen the second stage of labor, which is that pushing stage of labor, because you can't feel as much. Now, some people do find that as their labor progresses, things get more painful. And that is not because the epidural has run out, it is because the baby has changed position, and baby, as it gets lower into the birth canal, there's going to be more pain and more pressure, and they might need to give you more medication through your epidural. But it's not that the medication has run out, it's that the pain has changed, and the area that the epidural covers really, really well is right here. Let me back up. Right here to right here. So when baby gets down here, sometimes you still feel pressure and pain that we need to deal with. And we need to think about, okay, what's going to be faster? Feeling this little bit of pressure and pain to push the baby out, or if that's impeding your pushing, definitely getting an epidural bolus and having the anesthesiologist come back up there. But your epidural will not run out if you get it too early. That is just not true in modern medicine. Another thing that I have heard from patients and a little bit online is the risk of a dry birth. So your water has been broken for too long, all the fluid comes out, and baby's just chilling in there, no fluid, not happy. That's not a thing. So they used to think that this was a concern, and there certainly are concerns with having your water being broken for an extended time, such as getting an infection, but the baby is continually making more amniotic fluid through urine. Amniotic fluid is like urine and lung secretions, yum. And so the baby's not going to run out of fluid. Sometimes when our water has been broken, there can be some cord compression because there is less of that cushion, but we can do something called an amnio infusion if we need to, which is actually, they put warm saline in a catheter back up into your uterus. What we need to monitor with that is that we don't overfill the uterus and cause like a uterine rupture. So they're going to be monitoring the fluid coming back out and monitoring your uterus and making sure that it still feels nice and soft. So your baby doesn't run out of fluid if your water breaks. You might need more fluid to help cushion things, but there'll always be more fluid being made, generally speaking. And also, once your water breaks, it's not like, oh, the water broke, I have no more water, I'm not going to continue to leak. Picture that you have a wine bottle and you are trying to get the cork out, but you accidentally popped the cork in. The cork is the baby's head, and if you flip the wine bottle upside down and slosh it around, the head, the cork will move and water will escape out around it. And so if you're also having pressure from the top of the wine bottle collapsing, this is where the wine bottle thing doesn't make as much sense, but just picture that there's a cork moving, there's wine up there, amniotic fluid, that will continue to escape during your labor process. So it is not uncommon to, when you're having strong contractions or baby's moving around a little bit, to have a big old gush of fluid. And just know that your baby doesn't run out of fluid if your water breaks, and it's not a medical emergency, generally speaking, if your water breaks. In fact, it's part of having a baby. Another thing that I have had asked me time and time again is, will my milk come in if I have a C-section? And the answer is yes. Yes, 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 yes. Regardless of the means of exit of your baby, so a vaginal birth or a C-section, your milk is going to come in, because the milk coming in is caused by a hormone cascade of your placenta leaving your body. So your placenta is making progesterone and estrogen, and when that is removed from your body, those levels drop, and then so the drop triggers prolactin, which is responsible for your milk coming in. So your milk will come in regardless of whether or not you've had a C-section. Now, sometimes with having a C-section, because it might have been a traumatic birth, you might have gotten a lot of fluids, your milk might come in a little bit later, might take a little bit longer. On average, we see milk coming in between days 3 and day 7. But just because you have a C-section does not affect your breastfeeding relationship in such a way that your milk is not going to come in fully as it should. So don't worry about that if you have had a C-section, if you're planning a C-section, if a C-section is a possibility. It should not affect your milk coming in. Going back to C-section, and I'm going to discuss emergency C-sections here for anybody who does not want to hear about them. I have heard a lot of people say, I had an emergency C-section. And in the medical world, there is a lot of weight that comes with having an emergency C-section that most people, and this is not to belittle your experience, but in a way it might help you come to terms more with what happened during your birth. Most C-sections are not emergency C-sections. So they're called different things at different hospitals. At our hospital, we call it an urgent C-section. So a section that is not scheduled, but is not emergent. So an urgent C-section might happen if you come in and you were a previous C-section and you need another one, but you come in labor. If the baby is having some decelerations in the heart rate that are requiring a C-section, but they are not prolonged, they are not something that is an emergency right at that exact moment, but we're worried about it becoming an emergency, and we're seeing these reoccurrent dips in the baby's heart rate. If the cervix is not dilating as we have expected, if the baby is not coming down during pushing, those, for example, and there's many, many more reasons, but those are reasons why we would do an urgent C-section. But an emergency section, there is a period of time attached to when we make the decision to do that to when we do the incision on an emergency C-section. That is very important because time is of the essence in an emergency C-section. And most of the time, but not all, an emergency C-section will require general anesthesia. There wouldn't be time to put in a spinal. If you had a very good working epidural, the doctor might be able to bolus that up, but going under general can be faster. An emergency C-section is very stressful. The staff know how to handle it, but it's not anything that we want to have happen. And it seems chaotic probably to the patient. It's organized chaos, it really is. People are telling each other what to do back and forth, but it seems chaotic and it's scary. And so just because your C-section wasn't emergent, I'm not saying that it wasn't necessary. I just want people to kind of understand that there's a difference between an unplanned, unscheduled, or an urgent, as we call it, C-section, and an emergency C-section, where it's decision to incision, 15 minutes, and we can get that baby out in just a few minutes, and be life-saving for mom and for baby, depending on what's going on. So reasons why you would do an emergency C-section, just to kind of name a few off the top of my head. This is not to stress people out, but just to kind of let them think more about maybe the stories that have happened to them. The cord has prolapsed, so the cord has come down in front of the baby's head. We're having some sort of abruption, so a lot of bleeding from mom, an eclamptic seizure, or the heart rate of the baby has gone down and it has not come back up. Those would be reasons for an emergency section, just to name a few. So there is a difference between urgent, unplanned C-sections and emergency sections, and just to kind of know that terminology and know when you're talking medically, there's a very big difference on our end. So hopefully that maybe gave some people some peace about their C-sections, but either way, that's something that not all C-sections are emergency sections. In fact, most are not going to be emergent, but many still are necessary. Don't let them become emergent. We kind of do the C-section based on clinical judgment before that. Something else that I kind of, again, I don't want to belittle anybody's experience, but something that I think is really important to know is that labor is defined by cervical change. Contractions do not equal labor. Doesn't mean you're not working, and I hate the term false labor. I prefer practice labor, but contractions sometimes happen, and cervical change does not happen with them. And so that's not technically considered labor. So often when you hear people say like, oh, I was in labor for a week. You weren't actually in labor for a week. Based on the technical definition. Were you having contractions? Yes. Do contractions suck? Yes. But labor is cervical change. Okay? So I'm just putting that out there. Kind of the myth of 72-hour labors. Yes, sometimes they do happen, but labor is cervical change. If you were being induced and it took 3 days, probably weren't in labor for the first couple of days of that induction. And that's not to belittle anybody's experience, because I know it is no fun to have contractions, especially contractions that aren't changing your cervix, gosh darn it, but Yes, contractions are not labor. Labor is cervical change. So going off of that labor piece, something else that I want people to know is a myth is birthing hips. That mama's got some good birthing hips. No, 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 nay, nay, that is not a thing. Because I don't care how beautifully wide your hips are from the outside, all your baby cares about is what they look like on the inside, because that is the part that the baby has to come out of, not the outside. So if you have sisters who have had babies, your labors are most like your sister's labors because they're going to share the most genetic material with you to have a similar pelvis. So it's what's on the inside that matters, ladies, as we all know, but pelvises included. Birthing hips, while beautiful and voluptuous, and we love all curvy women, do not necessarily mean that you have an adequate pelvis. Same thing, being a skinny mini does not mean that you can't have your big old honkin' 9-pound baby, because it's what's inside that matters, ladies. It's what's inside. So another thing that I kind of want you guys to know is not 100% true. And again, a lot of these are half-truths. People think that if the baby has a cord looped around the neck or a knot in the cord or anything like that, that it's going to be the need for a C-section, emergency or otherwise. And that simply is not the case. About 1/3 of babies are going to have the cord around their neck. We see it often on ultrasound, and it's not even something that the doctors note because it's so common. It can be an issue, but most of the time it's not. Umbilical cords, first off, let's just say they are amazing. The whole reproductive system is amazing. Whoever came up with that, good plan. Maybe don't love, you know, something the size of a watermelon coming out of something the size of a donut, but besides that, great plan, because this umbilical cord is made to withstand getting wrapped up and tangled in baby. It's made to withstand some compression. It's got this wonderful stuff called Wharton's jelly to really kind of insulate it, and these cords are made to get through labor. Now, can a tight cord around the neck be a cause of recurrent decelerations and needing a C-section? Yes, it can. If that was the case for you, I am not belittling your experience, but we often see the cord wrapped once, twice, sometimes even 3 times around the neck with a vaginal delivery with no decelerations. Sometimes we think that there's a cord somewhere and then the baby comes out and we see no apparent cord. It might be that it was between the baby's head and the wall of the uterus or something, but a cord around a neck is not an emergency. It can be, but more than often it's not going to be an emergency situation. And having a true knot in the cord can definitely be an emergency situation, but often it's not. And often when the baby is born, they'll either be able to come through the cord or the doctor will slip the cord off from around their neck. Rarely the cord might be super tight. It was my case with Holden, and they had to clamp and cut the cord at the perineum. But we don't like to do that because then if there is an issue with getting the shoulders out, baby is deprived of oxygen. So birthing through or coming around and coming out of the cord are two things that happen quite frequently. You might hear the doctor call out that there's a cord around a neck, but in general, it is not something to be concerned about. It happens. Babies were made to withstand it, and with proper monitoring, if it does become an issue, then we can deal with it accordingly. Going back to breastfeeding again, I have a lot on here about breastfeeding. I think, okay, this is another one that's kind of a half-truth. That your nipples need to toughen up after having a baby. Yes and no. So chances are, and I think I've said this before, I don't know your life, but you probably don't have somebody vigorously sucking on your nipples for nutrients, you know, 8 to 12 times a day for 15 minutes at a time. If you do, you, no judgment. But in that way, your nipples are experiencing something new and there is some toughening up before it becomes less sore. But your nipples should not be cracked or bleeding. You should not want to throw the baby across the room the whole time that they're nursing. That is not normal. That is a sign of a poor latch that needs to be dealt with. Perhaps it's due to a tongue or a lip tie. Perhaps it's just due to baby needing some body work, had some tight neck or something else in labor, but it is not normal for your nipples to be that painful and that broken down with breastfeeding in the first few weeks. And if they are, I recommend seeing an international board certified lactation consultant to get some guidance on how to make breastfeeding comfortable. So soreness is normal, needing to toughen up, kind of normal in the sense that you have to get used to something sucking on your nipples. But should they be bleeding? Should they be cracked? Should they be blistered? No. So go see your lactation consultant if those are the case. Something else that is a myth that I think is pretty well explained to most women nowadays, but not always true, that you can eat for two. I get ice cream, baby gets ice cream, 2 bowls of ice cream for me. That sounds awesome, except for not so much, because you can't eat for 2. When you're pregnant, you only get about 200 to 300 extra calories a day. And depending on your BMI kind of guides what normal weight gain is for you during a pregnancy. For some women, they really shouldn't be gaining little to any weight. And I hate talking about weight because I know it's such a sensitive subject, but eating healthy is also the best thing that you can do for your baby for a good delivery. Eating healthy and moderate exercise. And again, discuss with your doctor before changing your diet or your exercise plan. But those are great things that you can do for baby. Now, when you're breastfeeding, you get 500 extra calories a day. And sometimes those are in the form of Chick-fil-A cookies, which, PSA, have oatmeal in them, which, PSA, can help you produce more milk, which, PSA, win-win. Get some cookies, get some milk. Okay, sorry, I'm weird and awkward, but y'all knew that. So, the very, very last one I want to discuss, the myth or the wives' tale that if you have more heartburn, your baby will have more hair. And y'all, this one is true. What? So, it is not that the hair causes the heartburn, but extra estrogen relaxes your esophageal sphincters, causes more heartburn. Extra estrogen causes more hair. So, if you have bald babies like me and don't get any heartburn, I'm sorry. But hopefully if you're having lots of heartburn, it means that your baby is also growing lots and lots and lots of beautiful, luscious hair, because I love hairy babies. Anyway, I want to thank you guys so much for watching. Definitely leave, if you have any other myths that you know aren't true or are true, leave those down below, and I'll see you next time. Bye, guys.